Sure. My name is Carmen Clelland, and I do go by nickname of Skip, so that's fine for Skip. And I started my career within the Indian Health Service and spent 20 plus years within clinical functions within the Indian Health Service, and then also administrative services within the Indian Health Service. Later, the past 3 years, I've been working at the CDC. During this period of time, though, I've always had an interest in medication adherence, the issues of medication adherence, what it means to a patient level, provider level, public level, as far as how can we identify ways to help provide solutions to medication adherence, and why it's such an important issue to address overall as a public health issue. Sure. The apps that we were looking at because the overall greater focus on public health medication adherence. Now, when I talk about that, what I'm trying to explore is how can we use public health data along, or just regular, even big data, along with the information that we would get from potentially a patient medical record through an EHR in aggregate data form for physicians, for pharmacists, for patients, for public health professionals in order to drive a change in dynamic in how people view medication adherence. So the goal is if we were to identify how medication adherence is within a county or a census tract, or in case one of the areas that we were thinking of is a tribal tract, and be able to say in this part of the city, or this part of the reservation, or this part in rural America, or this part in a county, that you know that your adherence rate on a certain medication is 60%. Well, how could we identify that in order to drive medication prescribing patterns, maybe drive education, maybe drive other factors that might be involved, even to planning of cities or planning of rural areas, and making sure that we address it on a more public health role issue, looking at population health, then being able to help improve that patient's ability to have all the things they need in order to have better medication adherence practices. So that was the goal of this, and it sounds kind of lofty. So one of the things I worked with the teams, I had two teams, and it's interesting because the interaction between the two teams was different too. One was very engaged. The other team was slightly engaged, although they did need that subject matter expertise. You know, being a clinical pharmacist, all those years, I was able to provide that to that team with some information, and then a follow-up. And so I met with them maybe just a couple of times. The other team, though, was more engaged. They wanted to have some more input about what medication adherence was. Why was it this issue? Why did I think that fire technology and being able to develop strategies to help support that technology in use of population health data could help solve this issue. So I went through with that team my thinking on this and why I thought this could be a way to look at it. So they were very much engaged and ended up developing a nice framework concept with regards to that would lead to a proof of concept at some point in order to see, can we develop these applications using fire technology, big data, insurance claim information, potentially Medicare claim, Medicaid claim data, all those things that can be accessible, and then using it to be able to use it as a population tool to help prescribers, pharmacists, patients, and then public health professionals to develop the right strategies to improve medication adherence. Because if we make just an overall group strategy of doing medication adherence, it may not apply to the person in the inner city versus the person in the rural versus person on a reservation versus person living wherever they are. And having better aggregate data in those population areas that we want to really focus on will help drive better prescribing patterns from physicians, better counseling from pharmacists, better ability to take the medications from the patients, and better public health campaigns from the public health practitioners. So that is the strategy on that. So the framework that they had was, the one team developed was called the Medication Adherence Support System Conceptual Architecture. And what the goal of that was to look at it from that perspective of not only just always focusing on that patient perspective, but looking to see who are all the people that need to interact with that. And then how does that interaction need to coordinate together to be able to drive the information into the interface, the data into the interface, and then being able to regurgitate it out in a way that is meaningful to that physician, still meaningful to the patient, meaningful to the pharmacist, meaningful to the public health practitioner, and supporting the overall goal of, I want that patient to be healthy, I want them to be able to take their medication, and we know if they take their medication, chances are they will have mostly success with whatever chronic disease or other issues that they're working to deal with. And so that was how that architecture was set up. As you look at the architecture that they developed, it really is strategic in nature, where you can actually focus on various elements of this concept architecture and continue to develop maybe one module of it here and another module later in order to some point have, in 5 years maybe, have the full architecture put together that would then you could go out and use to be able to help drive public health medication adherence, and then eventually affecting it as a population strategy. So that's how the architecture was developed, and it's very detailed in how they came up with that conceptual architecture. What the team did that did the conceptual architecture, they also worked on an initial component of an app, which is the patient-facing app. And probably for most of the apps that we see, that's probably the easiest. Because it just requires patient data input as far as, did they take the medication, what time of the day did they take it, those types of things. And there's a multitude of those out on the market. So that was the first strategy that both teams actually ended up creating examples of their apps in doing that and what that would look like. So, and they had both of them had some good components to it with regards to when they missed doses, what was that, or what was the cause of missed doses. One of the things that I cautioned them on that is when you're talking about the patients, there's this whole fatigue issue and of being overwhelmed by always having to put stuff into a program or having to hit a buzzer or something to that, where eventually you start phasing it out and it just becomes background noise. And how do we use that strategy in the future to help prevent these things, where you get your key information into those patient-facing apps and then being able to retrieve that out at the other end, so that way the physicians and the pharmacists and the public health people can have access to that information, clean of course, so that way it doesn't identify patients at a patient level, but enough where they can say, in this urban city, in this urban area in Atlanta, medications in Ward 6, is only taking hypertensive medications 40% of the time. What is in Ward 6 that is creating this as an overall thing that we'd want to explore? And then you'd be able to say, now I can do it because I have the data. I can go to my city planner, I can go to the pharmacist, I can go detail physicians and let them know this is a strategy that they can do. And so that's how that architecture was set up to be able to support that and make it into something that's workable, usable, and eventually in the end be something that can make an impact. I think the next step, it needs to go in a couple of different phases. Clearly there's work done initially on the patient phase, but it's not complete, as these were, I can't remember how many weeks the sessions were, but so they had limited time with their team together. There still needs to be work on that patient app. There needs to be development on how to build in the FHIR technology, bringing in the FHIR technology along with big data to incorporate it, so you can start seeing conceptually how big data impacts decision making at a county, census tract, tribal tract, other population modalities of how you identify groups of people, and then bring that into an application, because I think that's when you'll start seeing how you can drive this information. There's plenty of patient apps out there that you might be able to get this information from, and I'm sure there's a lot of people skilled in looking at it from that perspective, since that's the most common way people would use to help say, I can help improve adherence. But then driving this other point. So I think the next phase for me and what we're looking at with this is to drive that population health data gathering along with access to some sort of patient record system that includes claims data, those types of things that would be able to make this a more comprehensive look at medication adherence. Then with that, look at that population health part of it and then seeing how can we affect health equity because of what we're using now with data making decisions versus the anecdotal information you tend to get from patients. Oh, I took this, or the late dose. I'm going to start taking this a week before my doctor's appointment so that way it doesn't look like I'm not, or other things. And it's not necessarily all the patient's fault. It's just the way our system is set up to not necessarily look at medication adherence as an issue. It's more or less the chronic disease issue. But if you're spending hundreds of billions of dollars a year on medications and there's a lot of that being wasted, then we're looking at also something that can have an impact on our healthcare system overall, as well as our public health systems overall too. So that's the next strategy on this. All right, thank you.